We've heard some very, very convincing modelling data. I don't think there's anybody in the room that would not believe that if we get on and start treating more people with better treatments, we're going to turn the curve. What I'd now like to move forward to is some examples of best practice. Our first speaker comes to us from that other kingdom of Scotland, John Dillon, who's consultant in Ninewells in Dundee, and also the chair of the Scottish HCV Action Plan, can actually demonstrate what can be done if health service actually prioritises hepatitis C. I think we've got representatives from the Mayor's office here. If ever there was an argument for a devolved health budget for London, I think what John is going to show us what Scotland have done is a very good argument. Over to you, John.
Okay. Thank you for inviting me back to London. I was here for 25 years. I left shortly after I qualified, but thank you for asking back. I love models, but I think we need to get down and dirty in the real world. So you've asked me specifically to tackle the problems of getting PWIDs to cures, and I'm going to condense 15 years of work in Scotland and across the whole action plan into 7 minutes, which is some issue. So first of all, the first problem is getting a diagnosis. Many people don't believe that they're at risk. There is a stigma about being at risk. It's difficult to access a test. If you've got to go to your general practitioner to get a test, how many times does it take you on the phone to get an appointment to even discuss a test? That's not going to work. There is a case for screening, and I've not been asked to address that today, and we haven't yet tackled that one in Scotland, but we'll see about it. Referral. How do you make that referral? If you've got a diagnosis, how do you then get someone into treatment? There is medical ignorance. Most people who are qualified medical practitioners in this country left medical school before hepatitis C was discovered. They know nothing about it. You've got to educate your medical practitioners. Patient ignorance is probably less of an issue. They're becoming much more aware about it, and perhaps they can educate their medical practitioners. We need to get away from this whole idea of worthiness of referral, patients believing themselves not worthy of referral, and the medical practitioners involved with them not believing they're worthy of referral, and we dealt with that in the Scottish Action Plan. So, about access, this is an expensive, complex therapy. Do we need to deliver it in a teaching hospital, which is where most of the centres are? Are we really going to make our patients travel 130 miles in round trips to get to see me for 5 minutes in outpatients? Make them come to see me 5 times before I decide they've got over enough hurdles to come into treatment? Multiple outpatient visits and bringing them into an environment where they have a stigma and a fear of hospitals because of the way they've been treated in the past. Getting them out of jail to come to treatment is another major issue. We've got to think about their comorbid diseases of drug addiction, how we cope with their methadone, HIV, cirrhosis, depression, and the therapy was complex and had side effects, etc. So we thought of all those things when we came up with the action plan for Scotland. How did we solve them? We had a professional and public awareness campaign. Every medical practitioner got sent various little games, etc., to play with to raise their awareness about hepatitis C. There was much outside. Diagnosis was about raising awareness that people needed to get a test and making that step into testing and making it easy for them to get a test and using new technology, which I'll discuss in a minute. Care pathways are key. There is no reason why a patient has to travel into the hospital to see the specialist. They can travel out. My territory is 140 miles east to west, 110 miles north to south. I am responsible for delivering services across that area. We have 2 cities, 25 towns. We have 18 outreach centres across the whole area. A team of 3 consultants who provide 8 hours of care a week and 2 whole-time equivalent nurses, and we deliver care across that whole area. That's all it takes. It's not complex to do. So our outreach services go into the drug problem services, into the prisons within our area, and are scattering across to address our geography. I'll talk about referral barriers in a minute. We have a very nurse-led treatment model, so most things are delivered by nurses, by protocol, and if there's a problem with protocol, we come and get into them. And the key thing is, these models are all very well, but what they give you is a treatment target. You have to hit your target to know what you're going to do to get rid of it all. And equally, then there's an audit cycle, and we come round and point fingers at you as to why you didn't hit your treatment target. There are 14 clinical leads across Scotland. We sit in a room 3 times a year. The performance data is up there, and each clinical lead has to explain why they haven't hit their target. And you very quickly get a move towards the average and towards the target, because no one likes to have the finger pointed, particularly when it's then followed by a government visit or our devolved government, and starts to say, if you don't hit your target, we take your money away and give it to someone who is. So, thinking about some of the prime examples. Dry blood spot testing. So what happens here is that we have a finger, you have a needle, you stick the needle in the side of the finger, you squeeze it and you drop your blood onto these little cards. You wait 10 minutes for it to dry, you then stick your stamp on it, stick it in the post, it's completely legal, and send it to your lab. They stick that in their normal machine after diluting it in a little bit of fluid, and it goes through the routine services, so there's no extra things required. You then get the result back. So what we've done is trained over 100 staff in dry blood spot testing, mainly third sector workers and volunteers. HCV testing becomes embedded in clinical practice, so we've got them in the drug problem centres, in drug testing and treatment order centres, in the homeless outreach centres, social work departments. We have social workers doing dry blood spot testing, criminal justice, minor injuries units, prisons, needle exchanges. Most of our dry blood spot testing has been done in needle exchanges and at action. 81% of the tests are carried out by support workers without any clinical qualifications. If you can do a test or you can read a test result, you can refer. Everyone has to be part of the network. They send us their email to come to the network. And once they're part of the network, they can refer to me. So you've taken out all of those barriers. One step, one person, referral into treatment. What that does to you, this is 2010 data. In the first year we introduced dry blood spot testing, we doubled the numbers of new diagnoses instantaneously. We have now diagnosed across Scotland an extra we've doubled diagnosis from 1,100 per year to 2,500 patients per year. So we haven't had an impact on those patients we were testing already. We reach the parts you can't reach anywhere else. Once you get patients who are of a drug-using background into treatment, there is no difference in outcome. So diagnosing these patients is worthwhile. They are just as curable with complex, difficult therapies as anybody else is. It makes no difference. You can cure them. So how do you wrap care around PWIDs? First of all, what do you mean by PWIDs? And I haven't got time to go into that now. Use what is already there. Go to where there is a natural flow of your patients. There are statutory providers. Think about the third sector. Most of our needle exchanges, most of our preparation for movement into addiction services are provided by third sector charities. Embed things in there. They're often very receptive to it because it makes their management of the patient's drug addictions much easier, and it leads to addressing other agendas. Use an octopus approach. Do not build empires. You want to creep into every little nook and cranny and find where they're going. Education, education, education. If you educate staff who are not used to having their education, give them a free lunch. Drug companies are very useful for that. You make them apply by email. If they turn up, you've got their email address, they are then part of the network. An instant network, and if they're part of the network, they're allowed to refer. And you've suddenly got your whole network established. You've got everything working for you inside. So what happens when you do this? We have now diagnosed 79% of our estimated prevalence in Tayside, in that huge geographical area I've discovered to you. We are treating nearly 8% of our eligible patients for therapy per annum. So 2030, bugger that, we'll have done it by 2023. Unexpected benefits. When we introduced dry blood spot testing, the needle exchanges took it up hugely enthusiastically, and we thought, well, that's not going to be much use for us. We can't treat patients in needle exchanges, can we? And then we discovered that we're actually accessing a group of patients that have a 20% per annum risk of acquiring new infections. So every time they did a test, they repeated it a year later. So 20% per annum in patients that are in needle exchanges and doing some harm reduction. If you think about our drug-using population, you can see the bottom line, but there are about 800 high-risk patients with a relatively low prevalence in our needle exchanges, and they have risk factors of perhaps 300 per year and a seroconversion rate of 20% per annum. So the Eradicate Hep C project is we are treating 20 to 40 very active PWIDs from the needle exchange. We are treating them in the needle exchange. We are embedding our treatment nurses there. We encourage them to bring a friend. We mind the vein. We pay them £5 a visit. If you make 4 consecutive visits, you get a tenner. It's part of a voucher scheme. I'll talk to you about it later. We offer them low threshold methadone. None of them accepted it. And our treatment endpoints are numbers of patients we can get into treatment and whether we can achieve SVR. And if that's successful, we'll then measure population prevalence at 5, 7, and 10 years and see what happens. But if you look at Matt's models, we are getting the very high-risk groups, not the ones that are cycling into methadone, the really high-risk ones, and delivering them. What's happened? We're now 15 months into the project. We have 35 patients initiated on therapy. We've only had 3 dropouts. One got arrested the night before he was due to start therapy because he nicked a police car. The other guy dropped out. The other guy dropped out of 4 weeks and didn't get an SVR. One other guy dropped out 16 weeks and got an SVR. Adherence is good. The contingency management is very popular. Side effects are relatively minimal. We've had one rash. They weren't on telaprevir. We are using interferon, telaprevir, and ribavirin in a needle exchange, seeing them weekly. If we can do that with that therapy, what can you do with DAAs? Early days yet. We've only going 15 months. We've got 6 patients through treatment, 5 cures. Thank you very much. So I disagree with the motion because we'll beat you by 7 years.
Thank you very much indeed, John. And